Hi, I'm Kayla Beckham.
And I'm Arita.
And I am Taylor Ellis, and we did our thesis project over the renoprotective properties of dexmedetomidine versus traditional pharmacologic methods. First of all, we want to acknowledge and say a huge thank you to our research committee, Megan, Professor Bradley, and Zach. We all know that acute kidney injury is a common postoperative complication of cardiac surgery with an occurrence as high as 40%. For the purposes of our study, we've kind of loosely defined acute kidney injury as a structural injury preceding abrupt loss of kidney function, leading to an increased serum creatinine level or a decreased urine output. Not only does an acute kidney injury correlate with a need for longer ICU and hospital stays, but it also increases mortality and morbidity for these patients from about 8% to 60% mortality rate when they are diagnosed with an acute kidney injury postoperatively. The cause of an acute kidney injury is very multifactorial, but it's of particular concern during cardiac surgery for a lot of different reasons. A lot of times these patients have suffered a recent MI, they have prolonged coronary pulmonary bypass use of a lot of vasoactive drugs. There's bouts of hypotension with decreased cardiac output intraoperatively, and then oftentimes there's use of an intra-aortic balloon pump as well. So with such a high incidence of acute kidney injury, along with an ever-growing acuity of our surgical patient population, we think that a development of an effective renoprotective method is extremely important as anesthesia providers. Current methods are dopamine or mannitol, and even with the use of these, acute kidney injury rates are still as high as 40%. So we found there to be a strong need for more standardization of an effective renal protection during cardiac surgery. We were unable to find much current research to back the use of things like dopamine or mannitol. A lot of the evidence-based practice that we did find was more than a decade old, which we were very surprised at as we considered dopamine to be the gold standard of renal protection during cardiac surgeries. So more recent research has actually shown that Precedex may be renal protective and could offer renal protection, especially during cardiac surgeries. So the purpose of our study was to determine whether or not Precedex could be a viable alternative to more traditional methods of renal preservation, more specifically to compare it to dopamine. As stated before, the cause of acute kidney injury is multifactorial, and a lot of things that occur during cardiac surgery while on pump lead to acute kidney injury. These include surgical stress and sympathetic nervous system overactivity, which can lead to increased epinephrine levels, norepinephrine levels, and renin secretion. And these patients can often suffer from ischemia and reperfusion injuries, as well as increased inflammation. So you might be wondering how Precedex offers renal protection. As an alpha-2 agonist, it decreases norepinephrine levels in your circulating blood, which leads to renal artery vasodilation and increased renal blood flow as well as urine output. Precedex agonizes those alpha-2 receptors in the renal peritubular vasculature and can actually improve perfusion to the renal tissues themselves. Precedex decreases the secretion of vasopressin and inhibits renin. Precedex induces a sympatholytic attenuation of sodium reabsorption, which leads to more secretion of sodium and water. Precedex also offers some anti-inflammatory effects by inhibiting the activation of the JAK-STAT signaling pathway. And then lastly, Precedex offers an attenuation of ischemia and reperfusion injuries to the kidneys.
So our research question is there a significant difference in the incidence of postoperative acute kidney injury in patients undergoing cardiac surgery that receive Precedex or dopamine? And our hypothesis is that dexmedetomidine is a more effective drug for renal protection during cardiac surgery than dopamine. This review is an example of exploratory research. We thought this framework fit the purpose of our study the best since we can't actually make official recommendations based on our research, but we've definitely found enough information to warrant further studies. Exploratory research tries to solve problems that haven't necessarily been researched in depth. It aims to gain familiarity with a phenomenon or to develop a more specific hypothesis, and it's not usually used to make decisions, but it can provide insight into a problem. So our first literature or study that we reviewed was actually a study that covered 10 randomized control trials, and it had a total of 1,575 patients. Along with acute kidney injury rates, they observed several secondary outcomes like mechanical ventilation duration, ICU stay, length of stay, and 30-day mortality. 6 of the trials used placebo for control versus their Precedex. 2 of them used propofol, 1 used morphine, and 1 used remifentanil. And then I think that they compared these just because they were looking at a lot of different factors of Precedex, specifically the benefit of sedation with Precedex, along with its effects or positive effects on acute kidney injury rates. So 6 of these studies used pre-bypass Precedex infusions, while the other 4 gave it postoperatively. There were 2 different administration strategies amongst all the studies. 4 of the studies did a 0.4 to 1 mic per kilo bolus, and then followed that with a continuous rate of 0.2 to 0.8 mics per kilo per hour. 6 of the studies did not do a loading dose. They just did a continuous rate of 0.04 to 1.5 mics per kilo per hour. Even though the administration times varied between intraoperatively and postoperatively, the research of the articles actually didn't find a statistical difference in the results. What they did find was acute kidney injury was significantly reduced in the Precedex group. And they followed that with several tests amongst all the RCTs. They looked at BUN, serum creatinine, urine output, and creatinine clearance rates. And while there was a significant decrease in acute kidney injury, they didn't actually find a difference in their secondary outcomes of mechanical ventilation duration, ICU stay, length of stay, and 30-day mortality.
We also found a randomized triple-blind placebo-controlled study that was aimed to investigate whether there is a dose-dependent positive effect of Precedex on neutrophil gelatinase-associated lipocalin levels, or NGAL, and renal functions when used after CABG. So NGAL is one of the newer biomarkers that we have to look at to see whether or not there is actually kidney injury. This study involved 90 patients that were split up into 3 different groups. 30 patients were put into a placebo group, 30 patients were put into a low dose Precedex group, and then the remaining 30 in a high dose Precedex group. So the low dose Precedex group received a concentration of 4 mics per mil, while the high dose was 8 mics per mil. These infusions were started post-operatively in the ICU, and they were titrated to keep the patient at a RAS level of 2 to 3. The authors of the study looked at NGAL levels, as well as BUN, creatinine, urine output, and creatinine clearance. They looked at these biomarkers preoperatively and then postoperatively at 24 hours and at post-op day 5. What they found was that for the more conventional renal function tests like the urine output, BUN, creatinine, there really was no significant difference between the Precedex group and the placebo group. However, when they were looking at the NGAL levels, it was very clear that there was a significant decrease for the dexmedetomidine group in a dose-dependent fashion. So those patients that received the highest concentration of Precedex had the most renal protection offered to them. The study did have some limitations where, it's a small sample size of only 90 patients, and then it was a post-operative administration of Precedex where we were hoping to find studies showing intraoperative administration. We found another randomized control trial that aimed to assess the effect of Precedex on both cardiac injury and renal ischemia reperfusion injury in patients undergoing cardiopulmonary bypass. This particular study had 50 patients in it, split into two groups. 25 patients went into a control group that received normal saline, while the remaining 25 went into a Precedex group. These patients actually got a continuous strip that was initiated 5 minutes pre-bypass and continued until 6 hours post-op. Every patient received the same dose of Precedex. They got a 1 mic per kg loading dose given over 15 minutes, and then an infusion of half of a mg per kg per hour, like I said, all the way through until 6 hours post-operatively. This study looked at a lot of different biomarkers here. They looked at urinary specific kidney proteins. They looked at norepinephrine levels. They looked at cortisol levels, as well as creatinine clearance. They looked at these preoperatively and then postoperatively day 1, 4, and 7. The dexmedetomidine group of patients developed lower levels of the kidney-specific urinary proteins at most of the time points postoperatively. They also showed lower levels of norepinephrine as well as cortisol, and they had increased creatinine clearance. So the authors concluded that the intraoperative administration of Precedex actually did provide renal protection for these patients.
And then we had another randomized double-blind study, and this study is actually our only study that compares dexmedetomidine and dopamine. So the purpose of it is to compare the renal protective effects of dexmedetomidine with dopamine in high-risk renal patients undergoing cardiac surgery. We had 150 patients in this study. All the patients had a baseline creatinine that was below 1.4. And they excluded any patients that needed an emergent CABG, needed a cardiac transplant, already had any kind of acute or chronic renal failure. So these patients are randomly allocated into two groups, so 75 patients per group. The Dex group received a continuous infusion of 0.4 mics per kilo per minute, and that occurred during their cardiac surgery, and then 24 hours post-op, while the dopamine group got an continuous infusion rate of 3 mics per kilo per minute, and that also went during their procedure and then 24 hours post-op. The markers for this study included creatinine clearance, BUN, and urine output. There was nursing staff during this study that prepared all the medications and would blindly give them to the anesthesia provider just so that they didn't know what patient was in which group. The findings in this study, they found that dexmedetomidine actually can reduce the deterioration in high-risk renal patients during cardiac surgery when compared to the dopamine infusion. Specifically, during days 1 through 5, the creatinine and BUN decreased in the Dex group, but it actually increased in the dopamine group. The urine output was increased in both groups, but the urine output amount was more significant in the Dex group. There was actually more acute kidney injury that occurred in the dopamine group. They actually had some patients that required post-op dialysis afterwards. So the limitations to this study were that they only conducted it in one facility. There wasn't a huge sample size of 150, and then there wasn't a control group that just got a placebo that they could compare it to. So this graph just goes with the study that I just talked about, just to kind of show you a visual. So the top left graph that you see there is in regards to urine output. The blue is dexmedetomidine, and then red is dopamine. So you can see that the urine output went up on for both of the medications, but just slightly more in the Dex group. And the top right picture is in regards to creatinine. So you can see that the Dex group had a lower creatinine than the dopamine group. And then the bottom left graph is in regards to BUN. So you can see that dopamine had quite a bit higher BUN values than the dexmedetomidine group. And then the bottom right is creatinine clearance. So again, you can see that the Dex group in the blue had a higher creatinine clearance compared to the dopamine group. So we had another study here that was a quasi-experimental study, and the purpose of this study was to explore if dopamine increases renal oxygen consumption, and this is actually our only study that solely focuses on dopamine. This study only had 12 patients in it. They started with 14, but one of them had to be excluded for post-op bleeding, and then another patient was excluded because they couldn't place the renal vein catheter. The study also had an exclusion criteria as well. So they excluded any patients that needed any kind of inotropic support after surgery, if they had significant post-op bleeding, or if they had any kind of post-op hypotension that was due to any kind of arrhythmia. So the 12 patients that they did include in this study were mechanically ventilated following their procedure and were sedated. All of these patients did have a normal renal function preoperatively. And then the markers for this study included renal blood flow, urine output, and filtration fraction. So these patients got dopamine at a rate of 2 mics per kilo per minute, and then they got the biomarkers for that, and then they would increase the dose to 4 mics per kilo per minute, and then get the biomarkers for that as well. So the findings in this study, they found that dopamine increases renal oxygenation, but there wasn't any effect on the patient's renal oxygen consumption or their GFR. The limitations to the study, of course, are the small sample size of just 12 patients. And then, of course, these patients couldn't be randomly allocated at all because there was only one group and they got the same kind of treatment. So there wasn't anything to compare it to. And then this next study was also a randomized double-blind study. The purpose of it was to investigate the renal effects of dexmedetomidine in cardiac valve replacement patients that were undergoing cardiac or cardiopulmonary bypass. There were 72 patients in this study. All these patients were between the ages of 18 and 75, and they were all ASA 2 or 3. The data collection occurred between February to December 2014, and they also had an exclusion criteria. So they didn't include anyone who had a heart block, any kind of severe left ventricular dysfunction, or if they had diabetes or any kind of severe hypertension. Or any kind of obvious kidney dysfunction. They specifically didn't include anyone who had a creatinine that was over 1.5 or a BUN that was over 9. So these patients were randomly, not random, well, yes, they were, they were randomly allocated into 2 groups. So into a Dex group and then a placebo group. So the Dex group got their infusion rate at 0.6 mics per kilo per hour, and that occurred for 15 minutes prior to their induction, and then they would decrease the dose to 0.2 mics per kilo per hour until the end of their operation. And then the placebo group got the same amount of volume, but they were just using NS for that group. So the markers for the study were creatinine, BUN, NGAL, SOD level, and urine interleukin 8 levels. The findings in this study, they found that dexmedetomidine may decrease renal injury and the incidence of AKI in cardiopulmonary bypass patients because the Dex group actually had lower levels of BUN, creatinine, and NGAL. So the limitations to this study were that they didn't monitor any kind of renal blood flow, and then there weren't any long-term follow-ups. This study actually monitored the patients at the 0-hour mark, 12-hour, 24, and 72-hour mark. So if it was anything after 72 hours after the study, they did not go and check on the patients at all after that. And then, of course, another limitation is the small sample size of just 72 patients.
So this last study that we looked at was observed a total of 1,133 patients for this cohort. This study actually did set parameters for their own definition of baseline kidney function. They based it on GFR, and they used that to see if Prestex was more effective in one group versus another. They designated 5 categories based on baseline renal function and GFR. And they did make a statement to say that distribution through the groups was similar in the dexmedetomidine and non-dexmedetomidine group. The outcomes they observed for this study was acute kidney injury, any complication, and all causes of mortality. And then the outcomes and measurements that they used for acute kidney injury included acute or worsening renal failure that they defined as an increase in serum creatinine greater than 2 milligrams per deciliter, or a twofold increase in pre-op creatinine, and then a new need for dialysis. They simply divided their cohort in half. One of them had received post-bypass Precedex strips, and the other just did not. And they weren't specific about the doses. They did see reduced rates of acute kidney injury for all of their GFR designations. However, they did see that Precedex was more likely to reduce rates in patients with normal to mildly impaired renal function. They most likely attributed this to decrease in reserve or impairment of normal autoregulation. This is still important because even mild renal impairment can increase risk of post-op AKI, and that can still really increase your risk of mortality. They did also see significant reductions in the incidence of any complication and their in-hospital and 30-day mortalities. So as far as limitations go, once again, this is a retrospective study. So they're looking at old data and potentially leaving out details as far as a full patient picture and how that might affect the results, but they still did a pretty good job of defining baseline kidney status and how that kind of plays out and the effects of Precedex on AKI. They also did not address dosing strategies or time frame for cessation of their Precedex strips.
Next, we have included a couple of tables that just kind of give you a broad overview of all of our literature reviews in one place. If you would like, we can send you, of course, a copy of this table, and it is also found within our actual defense paper.
Our project design was a systematic review, so we utilized exploratory research to evaluate the renoprotective effects of dexmedetomidine. So we basically just researched dexmedetomidine's potential in its use in renal protection. We had a total of 7 articles, and then one was a retrospective cohort, one was a meta-analysis that included 10 RCTs, 1 quasi-experimental, and then 4 RCTs. And then our methodology, we didn't perform a study, so we didn't have a sample or any kind of sample planning.
So this is just to demonstrate our data collection and how we found the articles that we ended up using. We did use the mesh search with the terms dexmedetomidine, thoracic surgery or cardiac surgical procedures, and kidney. We originally got 19 articles. 2 were excluded because they're pediatric studies, and then 11 were excluded based on our PRISMA guidelines. So that left us 6 in our final review. And then this was our search specific to dopamine. We essentially just exchanged dopamine for Precedex in our mesh search. That gave us 10 articles. We ultimately had to exclude 9. 3 of them were not based on PRISMA guidelines. 4 of them fell under a category that we didn't include in our definition of cardiac surgery. One of them was not specific to dopamine, and then one of them was a duplicate article. So that just left us 1 dopamine-specific article in our review. As far as limitations, our primary limitation is that this is just a retrospective review of old data. Even some of our studies that we reviewed were also reviews themselves, so we didn't get to see firsthand how this data played out, and perhaps we're missing the whole picture as far as this patient population regarding their comorbidities, baseline kidney status, and that can tie into our inconsistencies with these studies, in that there was only one study that actually defined baseline kidney status and how that might change acute kidney rates. And that actually was pretty significant. So the other studies didn't really address that too much. Another thing that kind of made it more difficult to compare our studies was that there was multiple different measurements used to measure the outcome of acute kidney injury. Amongst all the studies, there was creatinine clearance, BUN, GFR, and NGAL to define outcomes of AKI. It made it kind of hard to streamline our results. And then dosing and time of our administration varied quite a bit. Some started preoperatively, some was started right after bypass, and then others were just postoperative administrations. So current literature regarding any renal protection method is pretty limited. And that was an outcome that we didn't expect, was that there would not be much of a standard in place already.
And then again, we didn't perform a study, so there wasn't any kind of ethical considerations for that. Our recommendations, we believe that there needs to be more continuity in the renal protection methods that are used, and that there needs to be further research, and that they need to have more biomarkers and settings and rates and stuff like that that are more similar, so that they're easier to compare. So more studies with dexmedetomidine, dopamine, and mannitol, and then just in general, just more standardization is needed. So the evidence is needed so that they can hopefully develop a protocol for renal protection.
Okay. So in summary, we all know that our high acuity populations are particularly susceptible to the adverse renal effects of cardiopulmonary bypass. And I think that we've proven that there needs to be more effective strategies for renal protection because these rates are still as high as 40% within our patient population. While dopamine may be a more traditional method, current studies do support Precedex as a strong possibility for evidence-based renal protective option here. We just need more consistent and concise studies to confirm these claims, but there's obviously a need for standardization on effective renal protective methods during cardiac surgery for our patients. And then here is a list of all of the references that we used within our research. So thank you for listening to our project, and let us know if you have any questions at all.